Good evening, everyone. We'll be starting now. Um, with me among the panelists, I have my name is Dr. Ikechukwu Olasi. I'm a general laparoscopic surgeon and the head of surgery at the Redus Center for Digestive Health, Lake Lagos. I have with me to moderate this discussion Dr. Evaristus Chukwudike. He's a gastroenterologist and hepatologist, and I'm currently the head of endoscopy at the Radio Center for Digestive Health. We have the medical director and chief executive officer of Radio Center for Digestive Health, Dr. Kenechukwu Chudi Omugaje. He's going to start off the discussion with just a short presentation that reviews early onset colorectal cancer with special attention to what the current situation in Nigeria before we have the rest of the discussions coming. Kenneth, if you're ready, you could start, sir. Thank you.
All right. Good evening, everyone. We want to thank you for taking your time to join us this late to have this conversation. March is Colorectal Cancer Awareness Month, and we thought it was important to have this public health series where we talk about colon cancer and especially highlight what we're seeing more in Nigeria now, which is early onset colorectal cancer, where we see cancer cases in people who are younger than 50 years of age. On this call, we have a diverse group, mostly just from the general public. We have some medical people on the call as well. And so we'll be keeping the conversation at the general level so that everyone can follow along. So, my goal after we're done with this brief talk is just so that we can all have a full understanding of the epidemiology of colorectal cancer in Nigeria and specifically the early onset cases that we're beginning to see now, and also to understand the risk factors that can lead to colorectal cancer, be able to identify the signs and symptoms that may suggest underlying colorectal cancer, and then empower us with prevention strategies that we can take to reduce our risk of developing colorectal cancer. Now, these are a few people that some of us will know who have died from colorectal cancer. And I think, this sort of brings it back home that the ages that you see on screen go from diagnosis at 39, death at 43 to 61 years. Of course, it can happen to people who are much more advanced in age as well. But we're also seeing it younger too. We're seeing it in people in their 20s, in their 30s. And these are people that we know. Sonny Okosun is a popular Nigerian musician, from the 90s. He passed away from colon cancer, and we're seeing it younger and younger back in Nigeria now. And what is a colon? We know that from when we eat food, we put the food in our mouth, you chew your food travels down this long tube here called your esophagus. And from here, it goes into your stomach. The food sits there for about 2, 3 hours, it mixes up with acid and juices in the stomach. And from there, the food moves down from here into your small intestine, where a lot of the nutrients will get reabsorbed. The food keeps making its way through, and then it comes into this area called the colon. The colon is also known as the large intestine as well. And as the food makes its way through here, this is where your stool now begins to form. A lot of the water from it is reabsorbed. And as it moves down, your colon is about 1.5 feet in length, and a lot of reabsorption of water happens. Now, the colon has certain segments to it. There's this area called the cecum, which is sort of the first part of the colon from your small intestine. There's the ascending colon, there's the transverse colon, there's the descending colon, there's the sigmoid, and then there's a rectum. Now, this images you see here, this is the endoscopic image. This is if we were to put a camera through your rectum into your colon when you're cleaned out. This is what we'll see. You can see the walls look all shiny and sort of pinkish. This is a video that shows what the colon looks like. So this is a colon that has been cleaned out during the colonoscopy, right? And you can see there is no stool in the colon. You can see some, healthy blood vessels that run around it, but it's an open, sort of like an open, hollow viscous. And so there's no growth on the wall. Everything is smooth and shiny. This is what your normal colon should look like. This is what we see when we do your procedure to take a look. Now, how does colorectal cancer form? Now, we know that what I just showed you from that video is you said you have your clean colon, everything is smooth walled, no issues with it. But cancer develops when there's an abnormal growth in an organ, disordered growth. And in the colon in particular, before cancer develops, it gives us early warning signs. It starts as small growths that are called polyps. Now, over the next 10 to 15 years, those polyps will have more changes happen in them, more precancerous, cancerous changes that will eventually lead to cancer developing. So it gives us sign and there's a time. Now, you can see the progression and the growth here from just smaller to larger and then to invasive cancer. Now, if you look at the lower pane here, where we have um, the endoscopic pictures, you can see that this first picture, we have just a small growth here, really small, not big yet. But with the second picture, you can see how much bigger it is. At this point, what you're seeing there is a cancer that has almost obstructed the lumen, which is the space where your stool should be passing through. And our goal always is to prevent things from getting to this stage. Can you all still hear me well?
Yes.
Oh,
Yes,
okay.
yes, can hear you.
All right, just making sure you're hearing me. All right. Now this is what a polyp looks like, right? This is sort of the growth in the smooth colon. You can see your colon is still smooth, but you have a growth there. Now, this sort of growth is what we call a polyp, and over time, this can get bigger and bigger and progressively bigger till cancer develops. And so, when we come to prevention, we'll talk about it, but the goal is always to remove these growths before they get bigger and lead to cancer. Now, with regard to colorectal cancer, we have almost 2 million cases diagnosed every year globally. Out of these cases, we have between 900,000 to a million deaths every year. So it's a significant cause of cancer deaths globally. We know that most of the cases that we see globally, though 90% of cases and deaths happen in people who are more than 50 years of age. So they are much older, they've lived life, but over the last few decades, we begin to recognize that we're seeing an increased number of cancer cases in those who are younger than 50 years. But in Africa, it's even more worrisome, the proportion of early onset colorectal cancer cases we're seeing, including Nigeria. So this is just looking at the numbers in Nigeria. Now, we don't have great data in Nigeria because, our research systems aren't quite where we need to be yet. And so we can't see how many colon cancer cases we have in the country and look at all the numbers. But we know that colon cancer is one of the top 5 cancers we see in men and women. And all of the studies that we see are showing that we should expect to see a increasing incidence of colon cancer cases in Nigeria and in other developing countries as well. Now, if you look at the African continent and the few studies that we have in different countries, what we see is that early onset colorectal cancer is the predominant pattern. Now, this is a table where there's a lot happening here, but in this study, what they looked at was what proportion of colon cancer cases are they seeing in people who are younger than 40 years, who are younger than 30 years? What proportion are in young people? And if you follow me and look at this table, the second to the last one, you see USA here. And if you follow me and just go along with the US, if you come to the last column, what proportion of colon cancer cases in the US are in people who are younger than 40 years? And it's just 1.9%. So barely 2% are in those younger than 40 years. But if you look above and look at studies in Nigeria, they are single center studies. But look at Ilorin, for example, the number 3. 30% of colon cancer cases from that study were in those younger than 40 years. If you look at Lagos, Shagamu, 23%. So almost every one of every four cases were in those younger than 40. But if you look beyond Nigeria, if you look at South Africa, if you look at studies in Tanzania, in Kenya, this is all high proportion of colon cancer cases we're seeing in those younger than 40. I'm sure if you include those between 40 and 50, we will see more of that as well. And so we're not sure why we have this phenomenon. We know that we have it though, and it's something that we all should be aware of and look into more. Now, what are the risk factors for colon cancer? What are the things that you need to be aware of? We know that there are things that we can modify and there are things that we cannot modify, that we cannot change. For example, you can't change your genetic stock. You can't change your family history and the genes that you've gotten from your parents. But there are things that we can change. So diet, for example, we know that eating a lot of processed meat, red meat, can increase your risk of colorectal cancer. Smoking can increase your risk. Drinking alcohol heavily can increase risk of colorectal cancer. Increased body weight, obesity can increase your risk of colon cancer. A diet that is low in fiber can increase your risk of colon cancer. There are some other conditions as well. There's something called inflammatory bowel disease, which is something we're beginning to see more and more in Nigeria now. It's a condition that can also dramatically increase the risk of developing colon cancer. Now, with regards to genetic risk, this is something that's important that we're all fully aware of. Family history matters. What happened with your parents, with your siblings matters. And it's important that we all try to know and to understand our family histories. So we know that if a person has one first degree relative with colorectal cancer, first degree means either your father or your mother or your siblings or your child, direct first degree, that increases your risk of colorectal cancer by 2.24-fold. If you have two first degree family members, the risk is even higher. And we know that that association is stronger if the age at which they were diagnosed was younger than 50. So it's important to know what happened to their family members, what cancer they may or they may not have had, and what age they were diagnosed at. Now, there are also some hereditary cancer syndromes where if you inherit such a gene, it dramatically increases your risk of colorectal cancer as well. Without going into a lot of detail, some of them cause what we call polyposis. Polyposis means that we look into the colon and instead of seeing just that one polyp I showed in that video, you see hundreds of polyps scattered throughout the colon, right? And people that have that genetic syndrome, they almost have 100% risk of developing colon cancer by the age of 40 if they have the one that's called familial adenomatous polyposis. We also have some non-polyposis cancer syndromes as well, which means that they wouldn't cause hundreds of polyps, but increase your risk. For example, something that we call Lynch syndrome. Just to give you a sense, again, we have talked about the normal colon, which is this, where you see everything looks shiny and healthy. You don't have any growths. It's all smooth. Now, if I show you a colon that has polyposis, that looks very different. This is what polyposis looks like. You can see just hundreds of polyps, just hundreds of growth around the colon. And with this increases your risk of developing cancer. And in this video, for example, there's someone who they had so many polyps, and over time, as we come down, you can see there's a cancer developing much lower down in their colon. So this is just to give us a sense of what polyposis is, hundreds of polyps in the colon. And this is a genetic thing. Now, why are we seeing more early onset colorectal cancer in Nigeria? The truth is that we do not know, right? We do not know. We do not know because the research is not robust. We don't have all the answers yet. But we know that whatever is happening is likely not one single thing. It's likely multifactorial. First off, we have seen a huge epidemiologic shift in terms of our nutrition and our lifestyle over the last few decades, right? We are eating a lot more red meat, a lot more processed food. The diet of the average Nigerian child is, I'd say, similar to what you have with a child who's growing up in the West. It's cornflakes, it's milk, it's golden morn, it's the same processed food. It's almost exactly the same. We also seen a reduction in fiber and in sort of our traditional diet that's always been a very vegetable heavy with our soups. And we're seeing a lot more obesity now, more sedentary lifestyles. Our jobs are more computer based. We sit down. And so things are a little bit different. There's also likely genetic and biologic factors at play. We know that things like Lynch syndrome and other genetic cancer syndromes can increase the risk of this cancer developing early. I know in my practice in Nigeria, a lot of some of the cases that we've seen of early onset cancer, especially cases that we've seen of people in their 20s, early 30s, having people who have had family members, parents, grandparents, or siblings that have also had colon cancer as well. So the genetic component is important. But because in Nigeria we have very limited genetic testing, I think that we really have under-recognized the import of this. In Nigeria now, I think we have only one lab in Nigeria that can do FAP testing in the country, and this has been in the last year or so. But we're not able to do genetic testings in the country. And most times we send these things abroad. They are very expensive, and so we just have a little appreciation of the scale of this. I have this another patient that saw recently in Nigeria, but for this patient, they were able to, they lived abroad, came back, but they were able to tell me just because they knew that they have Lynch syndrome. And that's because the patient had colon cancer, they had a sibling that had colon cancer, and they had a parent that had colon cancer. But if they didn't live abroad and have that testing done, they wouldn't have known. So there's definitely a contribution from that as well. There are things like pollution that could be at play, but we just don't know because we haven't studied these things enough. And then the other thing too is this really a new phenomenon, or have we always had early onset colorectal cancer, but we just weren't picking it up before now? As we all know, access to endoscopy is limited in Nigeria. And so a lot of the times people die from stomach issues, right? People may have stomach problems, they're having blood in stool and they say it's ulcer, they call it something else. And so it's, up to recently now, there's been more access to endoscopy, but it's still limited in many states in the country as well. So the long and short is that we don't know exactly why we are seeing this, but we know that we're seeing it and we need to do something about it, be more proactive about this. Now, in terms of just what are the signs and symptoms of colorectal cancer, our goal is not to wait to develop signs and symptoms, because by the time symptoms develop, is often advanced disease. At that point, people may have blood in their stool, they may have pain in their stomach, they may have difficulty with their bowels. So someone, for example, who had a regular bowel habit can begin to have constipation now. Some patients will describe a pencil shape to their stool where things are very narrow now. And that happens because the mass has compressed the lumen of the colon and things are coming out differently. Weight loss is also an important one as well, where the patient comes in and they've lost a lot of weight. And then something that, your doctor can often pick up in your blood test is someone that used to have normal blood counts, they develop iron deficiency anemia that is new for them. These are things that can point to something going on. And when disease is much more advanced, then you can have features of spread of cancer to other parts of the body. But like I said, our goal is really to make sure that we are picking up these things before symptoms develop or that we're screening for it. Because by the time symptoms develop, it's often too late. In terms of how we diagnose colon cancer, so the way we diagnose it, the ideal way is to do a colonoscopy. What a colonoscopy is a medical procedure where before we start, your doctors will give you something to drink to help to clean out and flush out your system. You're going to go to the bathroom a lot and poop, and your colon will become empty. And then during the procedure, we often give you a light sedative to help you go to sleep. We put a camera, it's a thin, flexible tube. We put it up the rectum and we go and travel through the colon. As we're doing that, we're able to project the images, the video on the screen. And so we can see exactly what's going on. And so we can see the lumen of your intestines and see what's happening. If there's something concerning, we can always take biopsies from it. Besides the colonoscopy, there are scans that we can do as well that can show much more advanced cancers and can help to assess the spread of cancer. And there's also blood tests that we can do to help to point to how severe things can be. Now, with colon cancer, the important thing is early diagnosis. Early diagnosis. If we diagnose early, then the chance of survival is high. We always tell our patients that, for people that come in stage one disease, where things are all still localized to the colon, there has been no spread. 9 out of 10 of them will be alive after 5 years. But for those who come with stage four disease, because things are already advanced, only 1 out of 10 will be alive in 5 years. So the stage is really, really important. We know that if you look at the studies done in Nigeria, survival with colorectal cancer, it's only about 47% of people are alive after 1 year of diagnosis. Now, again, what can you do to reduce your risk of colorectal cancer? There are things that you can do that we call primary prevention steps, and they include trying to make sure you maintain a healthy body weight. And so if you are obese, work as much as you can to try to lose weight, because with obesity, it puts your body in a state of inflammation, and that can over time lead to cancer formation and increase the risk of that. We also want to exercise. The target should be at least 30 minutes of physical activity every day. Besides that, we want to maintain a healthy diet. What that means is eating much more fiber and vegetables, fruits, whole grains. And we want to decrease how much red meat we eat and how much processed food we eat as well. We also will want to avoid smoking. Smoking dramatically increases the risk of colon cancer. And we want to reduce how much alcohol we take. Now, there's secondary prevention, and this is the one where we can all really be proactive. Like I had said before now, before colon cancer develops, it starts as a polyp. And the polyp is a small growth that is there in your colon. But as you can see with this on the screen here, there's that small polyp and there is a snare around it. We can actually cut out that polyp. If you cut it out, you remove the risk of it growing to become cancer. So with secondary prevention, the goal is to have colonoscopies done to screen for colon cancer. Now, with these colonoscopies, you want to do them when you're healthy, not when you have problems, but when you're healthy and you get to age 40 to get them done, to find these things out on time and remove them. Besides colonoscopy, there are some other tests as well that can be used. There's some stool-based tests, but they are not as easily available. And the gold standard really is to do a colonoscopy to find these early polyp lesions and take them out before they become cancer. Now, this is what it looks like when we do a colonoscopy to remove a polyp. Now, this was that polyp that I showed you, and that if this polyp stays in the colon over the next 10, 15 years, this could become cancer. During the colonoscopy, we can get a snare around it, cut it out, and you take it out. And that removes the chance of this ever becoming cancer again. And so you can see now the polyp is gone, there's no growth from it, and we can look at the rest of the colon. And so during your colonoscopy, we keep going through the entire colon carefully and taking out polyps as we see them to remove the chance of cancer forming in the future. For colorectal cancer screening, the recommendation in Nigeria is that anyone who is up to 40 years of age and who is at average risk should have their colonoscopies done or should have their colon cancer screening done. Now, what does average risk mean? Average risk means that you do not have any first degree family member that has colon cancer. First degree, second degree, depending on what the relationship is. But if you don't have that at all, then you should start doing yours at 40 years of age. If you have a family member who has had colon cancer first degree, then you should start doing your own screening. If 10 years before they were diagnosed, if that's less than 40 years. So let's say your mother had colon cancer at 38, for example, then you should start doing yours at 28. That's when you should start your screening. But the goal is that we want to pick up on these things on time. Now, this recommendation to start screening at 40 years, is in the paper with the Nigerian GI Society. But the reason why this 40 years was put out there, which is much lower than what you see in the West, is because the median age of occurrence of colorectal cancer in Nigeria is about 50 years of age. 50, right? In the US, it's between 66 to 68 years for men and women. So in Nigeria, we're about 16, 17 years younger than what we see in the US. So it is much earlier in Nigeria, which is why, because the median age is 50, we want to start screening 10 years before that in Nigeria. So most people are not fully aware of this, but anyone who is up to 40 years in Nigeria and is at average risk should start having their colon cancer screenings done. Now, some take-home points I want us to just hammer on before we go on to talk with our survivors is this. Colon cancer is something that we see now in Nigeria, and the pattern that we're seeing more is early onset colorectal cancer, people who are younger than 50 years of age. And this is something that we're not seeing as much in the West. We're seeing it predominantly in Nigeria and other African countries as well. The alarm symptoms for colon cancer can include blood in stool, weight loss, change in bowel habits, but we don't want to wait for symptoms to develop. At that point, disease is often advanced already. And so if you're at average risk, you should start getting your screenings done from 40 years of age. Again, the gold standard for colon cancer screening is to have your colonoscopy done. That way, we won't just be able to look and see, we can also take out those precancerous polyps, resect them so they don't become a problem in the future. And finally, there are lifestyle changes that we can use as primary prevention. Maintain a healthy weight, not smoke, not drink heavily, try to exercise. These are things that we can modify on our end. And the last thing I'll say is it's important that we all know our family histories. If you know your family members that may have passed and it's not clear what has happened, try to find out exactly what happened as much as you can. That will give you a sense of your own risk if someone may have had colon cancer and you were not aware. The other thing that we can do also is to share our history, right? If you or someone else has had colon cancer and your cousin knowing can help them go get screened on time, we have a duty to tell. I know that in our culture, we like to keep these things to ourselves and not share about sickness or cancer diagnosis. But when that increases your neighbor or your cousin or your brother's risk, there's a duty to share. And we should, I think we should begin to change that culture and begin to share more of these things. Thank you all. We're going to go on now to have the conversation with survivors, but I'd like us, if we want to get more information, to go to our website and we can get more information on colorectal cancer screening and what we can do to help to reduce our personal risk. Thank you.
Thank you so much, Kenneth, for that very excellent presentation. It was very clear, and the messages were delivered with precision. Thank you so much for giving justice to this very important topic. Without wasting much time, we are happy to have our colorectal cancer survivors, Mr. Dozie Akwarandu and Miss Tobiloba Oluwasina. These are people, for me, I call them the champions, of colorectal cancer education, awareness creation, and, what have you. They've gone through the thick and thin of the experience of colorectal cancer. They've been speaking out to not only educate people, but also to encourage those that are going through the, difficulties associated with colorectal cancer. We're going to go into this session of just interacting with them and allowing them share their own opinion. I'm going to call on Dr. Evaristus Chukwudike to take charge of this session. Eva.
Thank you, Dr. Lassie. Thank you, Dr. Kene, for this wonderful presentation. As we were talking, many things were striking. what is peculiar about colorectal cancer in Nigeria? You mentioned the early onset. And today we have people to not just people saying it. We'll see people that were diagnosed, there are people that were in that age group, in so many. And they, wonderfully, Dozie Akwarandu and Tobiloba, they were considerate enough to give us, to come out to tell people that, yes, I have been diagnosed and this is the age. So I'm going to, let me start with Dozie. I'll ask two of you at the same time, but Dozie will speak and then we'll hear from Tobiloba. To you, Mr. Dozie Akwarandu, at what age were you diagnosed of colorectal cancer? And what symptoms did you have then? What were the symptoms that actually, how were you diagnosed? Please let us know. Over to you, Dozie.
Okay, thank you, Dr. Everest. And I want to appreciate Redus for organizing this conversation. It's important that we continue to amplify these voices. So you organizing it is one thing that should be commended. So I'm appreciating Dr. Chudi and the management team of Redus. I hope you can hear me.
Yes. Loud and clear. Thank you.
Yes,
Okay.
we can.
So perhaps let me put on my camera briefly. I'm on a waiting. I'm waiting to catch up a flight to travel out. Dr. Eva, thank you for the question. I would want to state here that my cancer diagnosis was not straightforward. It was not just, most likely I was asymptomatic, and that perhaps could also highlight the emphasis Dr. Kene made about the early onset. So I had just celebrated 38 in 2019, and those symptoms were dismissed. So they were something like nobody looked at, suspected anything to be cancer. So to answer your question straight, I was diagnosed after 38 years, so I was just entering 39. Thank you.
So much. So at 38, getting to 39, that was when the diagnosis was made. And this, when we take it back to when Dr. Kene presented, he told us about the age at which a good number of people, most people were in the United States were diagnosed. We saw the other slide that said that people about just 1.9%. We can see, and this is also confirming the number we have for Africans on that slide. Okay, I'm coming to you, Tobiloba. Please, kindly tell us at what age you were diagnosed and what's actually led to your diagnosis. Toby, I don't know if you can hear me.
Toby, you are muted in case
Can unmute
you are speaking already.
That device. Hello, Toby. Are you able to unmute your device? Okay, so we can continue with Dozie until we get signal that Toby can unmute as just fine device. Okay, Mr. Dozie, let me ask you the second question. How did you cope with the news about the diagnosis? When you were diagnosed, how did you cope with it? You know, that could be something everybody will be thinking when you were diagnosed How did you manage the problem? How did you cope with the news? Please let us know.
Okay. Actually, like I said, my diagnosis or the cancer diagnosis wasn't straightforward. It was something that, like I said, I was off and on hospital. So in fact, I was treated, admitted for irritable bowel syndrome. But when he couldn't, they said I had maybe the ulcer has really destroyed my colon. So I needed a colon resection or something like that. So I was booked in for surgery. So it was after surgery that, in fact, during the surgery was when they found out there were a lot of lymph nodes. You know, about 4 lymph nodes were affected. So they sent the specimen for histology. So when it came out, I was invited. So that also shows I've gone through some of the modalities of the treatment before getting to know that it was cancer stage 3. So perhaps, you know, I've gone through so many pains, so many surgeries, and so hearing that, oh, this was cancerous wasn't really a big thing for me, because before I entered into that surgery, I was almost like dying. So it was like I defined mortality for myself. So on accepting what mortality meant, and seeing it as it is, uh, helped me to embrace it. So I could remember vividly when it was said that I had cancer. Yeah, I wouldn't say I my it didn't change much about me. I only smiled. The only thing is that the thing I know about cancer was that hence you have cancer, you're not going to survive it or you're not going to live it. So there was no much information about surviving cancer. So I looked at it, okay, that's the end of a man, death. So I asked the consultant gastroenterologist, I said, would I be able to live till October 2020? In fact, so I remember he asked me, what is so special about October 2020? So for me, it was, a mixed feeling. It was like a pack of, well, what could be. But like I said, I've really demystified death and the fear of death. So I didn't see it as any new thing. But to tell you, I was like, can I just be alive to see my daughter, who was just about 4 years or thereabout? She was like 4 years then. So I was like, can I see this girl grow up? So, and that gave me that moral to begin to ask deeper question: what can I do? So simply, um, yes, it changed everything about me. The news of that diagnosis changed everything. It made me to reset my entire being. It made me to begin to accept that life is nothing other than what you're doing for humanity. It made me to understand that there is nothing like being patient in life. It made me to understand that there is nothing you can offer to people other than hope. You know, so the diagnosis changed my life positively. It impacted me also negatively, but the truth is that I embraced the news. I embraced the reality. I accepted it 100%.
Thank you. While we're still waiting for Toby to connect, he's having difficulty. Looking back now, with the presentation we have listened to and all the findings you have made, could you look back and say, okay, this could be the lifestyle, are there lifestyle dietary or any other risk factor you could spot from the all we have heard, all the presentation I've made, and all you have read before, that could say, okay, that's what I'm thinking, or my family is thinking. This could be the risk factor that could be picked out that caused the colorectal cancer in your case.
Okay, I think without missing what I could say, there are a few things like the presentations simplified a whole lot of things. So from this presentation and from my personal experience and my journey, I could say, yeah, I had a very good upbringing, but I could tell you that growing up in my adolescent age, I didn't like food. I stopped. I don't eat much, so I could see myself as someone that lived a life that depended so much um, on let's say junk foods. I saw myself. I liked a lot of fries. I liked cookies. I liked things like that. So I depended so much on that. And I could say that I I was able to afford genetic testing to know what happened because there was no history of any cancer in my lineage, let alone colon cancer. So I saw my grandparents living longer, and saw my parents also. My father died at 87. My mom died also at 74, thereabouts. So none of my this thing had this thing, and the genetic testing I did also showed that it was a wide case. So, but answering your question, I think I could say that the culprit is lifestyle. And why am I convinced to say this? You see, in my treatment journey, I had a nutritionist or a dietitian, right? I did while I was treating cancer, and led up to after 3 years of treatment, I was on tailored nutrition, which actually can confirm that there are lifestyles, there are certain foods which contribute to us having colon cancer or having cancer, as the case may be. It might not be directly, might not be, yes, this is what it is, but I think it's a contributing factor. So in my case, I would say that, yeah, people around me can also testify because I could go months. I could go months without eating cooked food. So, and having, as a civil engineer, I started practice at 26. So, being that I was living from one town to another, I was working for like 18 hours. I worked for like 18 hours as a civil engineer. So, those contributed to what I could say that made me to, yeah, I was active even till when I was diagnosed. But I think lifestyle, my diet, I could say, contributed to my having cancer.
Thank you. Thank you. So you have made very excellent points on the possibility of diet, which though couldn't say specifically it was diet, but you could say that some lifestyle could be a possibility. We are still waiting for Toby. So I want to ask you another question. So can you just walk us through the key events that took place from the diagnosis to treatment? People want to know, how were you treated? Looking at you now, if you don't tell somebody that you had colorectal cancer and you were cured, nobody would ever think about that. You can tell us what happened, because I will have people here that want to hear how you were treated. Outside it, like you had it in the first time, many people will think that that's a death sentence. Many people hear colorectal cancer is a death sentence. We tell us we are seeing survival, so that others can pass this message beyond people that are on this platform. Others who want to play this video and know, even those that have colorectal cancer now, that somebody that survived it. I think it's an area of hope to everybody. Please tell us.
Thank you. It's important to also talk about the stage, which in that presentation, like stage 3C is an advanced stage colon cancer. So I was it was an advanced stage. And as such, I couldn't escape um, those modalities. So I had, like I said, I had multiple surgeries, then had colon resection, then had, I think, is it anastomosis or something? Then had the corrective surgery too. But that's also another thing. But I went through chemotherapy. So I didn't really, there's something that is important here for me to say. A lot of people, when they had it was cancer, never wanted me to go through chemotherapy. And I still say it, I don't see it as bad intention. They had good intention. A lot of issues came up, spiritual attack and all the rest of them. But I was convinced that if my body could develop this, because I was convinced that nobody attacked me, so I could as well go through proven treatment modalities. And that's why I opted to do chemotherapy. So I had surgery, I had chemotherapy. So I also had immunotherapy at some point, So, and that is all that I could tell you. But I'm also using this opportunity, like I always say, that is there are so many stories of healing, miracle healings, so many stories of quick drugs or herbal healing drugs, right? In as much as I want a supportive care, in as much as I want an integrative um, care or treatment, I say that the proven treatment are what we are talking about. People can, even when you're not cured 100%, but you can live longer. This is my 6 years plus surviving stage 3C colon cancer. So having those treatment modalities will help you to sustain the life that you have. It's important for us to know that death is inevitable. So it's not only someone that has cancer that will die. So having that at the back of your mind and defining what mortality means will help you to take away the fear. So I know that a lot of people have been afraid because they hear chemotherapy kills, radiotherapy kills. So I'm here to say that I went through those and I'm still here standing. Thank you.
Yeah.
Thank you. So you had surgeries, chemotherapy, and radiotherapy, and you are alive. And this is a very good source of hope to those that are going through the same problem now that are being treated. Okay. Please, briefly, because of our time, we also want to listen to Toby. What is your do you think the family, what is the role of your family support or support you had in this treatment? Because that's a very big challenge when people are diagnosed of cancer.
I say surviving cancer, support is key to surviving cancer. Your environment is key, is even a very critical aspect of surviving cancer. So the role of family is something that we cannot take away. So I'm happy that I had a supporting family. And I was also very careful. What I did in my case was to I created a boundary, I created barriers to everything that I wanted to listen to. So if you're positive, I draw you closer. If you're negative, I leave you alone. So family support, friends, community support is very important in surviving not just colorectal cancer, any form of cancer. So I am here to say that I had a very good family support. My immediate family was there for me. My extended family also were there, and I limited people that I wanted um, to suggest what should be done. Thank you.
All right, thank you so much. That's great. Okay, so let's see if we can Toby is having a challenge, but Dr. Kenny has some slide we can share about her case. Dr. Kenny, please over to you. Let's hear about Toby's case.
I just got to know that I'm the youngest colorectal cancer survivor in Nigeria. That is so amazing. I feel good. Melin. So my name is Tobiloba. I'm a colorectal cancer survivor and I'm a permanent colostomy. My colostomy is about 4 years now. And I was diagnosed with colorectal cancer when I was 18. Now I'm 22. I was declared cancer-free June 2024. My sister said when she knew that they brought out the tumor was when Professor Rabot told her to go and get the biggest boy you can get in the whole of UCH, you should get it. She said it was so heavy, meaning that the tumor was so big. So when I woke up, they were just narrating everything to me that it has affected and spoiled my rectum. So they had to bring my rectum out alongside the tumor and then seal up my anus permanent. So now I have what we call a flat butt, meaning that I have a permanent colostomy. I cannot use my anus to poo anymore. I now use a colostomy. When they did the colostomy at first, it was challenging. How would I tell people that, okay, I'm pulling from my stomach? It would be so embarrassing. But I thought about everything. What if there's no procedure like a colostomy, like a stomach? I will not be alive. So I call the colostomy I have is scar to my victory of overcoming cancer. So, and when I started posting online, different people from diaspora decided to send me good quality bags because in Nigeria we don't have good colostomy bags. The colostomy bags they sell in Nigeria will never boost your confidence. I cannot use Nigerian colostomy bag and say I want to travel from Ibadan to Lagos. It's not possible. It will remove. I'll be covered in poo and everything. But thank God for good people. It affected me mentally to the point that I felt suicidal. Suicide was ringing in my ears. I used to say I'm a strong person, but deep down, it got to the point that I wasn't strong anymore. Seeing everybody around me, my family, everybody stagnant, everybody focusing on me, I felt like a burden. I felt like, okay, maybe if I end it all, of course, to pay them, they'll cry, they'll move on. Maybe that's right. And it also affected me socially because I used to be a very, very jovial person. So I just stay on my own. I don't go people, I don't hug people, I don't laugh, or just there. If you see me sitting down, I'm gone. So I needed to move back. I needed to just be on my own. And thank God for family. I told my sister that day that like I still want to keep myself. A lot of people called me, they advised me, told me that we are in this together and thank God I'm here today. Having colostomy, having a stoma is not the end of the world. You can be who you want to be. You can do a lot. You can get married. You can travel. You can swim. You can do literally what a normal human being can do. That's basically what I'm preaching on my social media.
So much. Dr.
Yeah, Bene. Eva.
Yeah.
Just before we continue with the rest of the questions, we have one or two attendees that would like to make a comment. I think they've been given rights to do that.
Yes.
If we could allow them, then we can continue. We have Okechukwu Nwobo. Please go ahead, sir, with your comments or questions.
Hello, good evening, right? Good evening. This is Valentine. Can you hear me?
Yes, we can hear you.
Good evening,
Thank you.
sir.
This is Valentine. I just wanted to say kudos to you guys. You guys are doing a phenomenal job. This is wonderful. Thank you so much. Dr. Lasi and Dr. Onwugaje, these are my very good friends. We all train together. So you guys are doing phenomenally well. And I hope this will encourage a lot of people. So please keep up the good work. This is phenomenal, okay? I know that it's not easy to practice in such a system, but you guys are doing your best. Even out of the little that is obtainable there, you guys are doing well. So just straight to a few questions I may have. First of all, I'm really inspired by the two, patients who've had colon cancers. And I'm happy that you guys are living testimonies to, encourage and inspire other people, right? So to the first, if it's possible, can I ask a few just clarification from the patients? Is that allowed or no?
Go ahead.
Okay, I think the first person is Dr. Chukwu. Is it the engineer, right? The civil engineer. Thank you so much. And I'm really happy and I rejoice with you for the survival. This is a great miracle, okay? So I just wanted to know, by the way, I'm a pathologist and a molecular pathologist, okay? So I just wanted to know just what was the location of your own cancer for the male? And if you don't mind, you don't have to give me a definitive answer of your age. The ballpark of how old were you at that time? And what was the location of the cancer, if you don't mind? I don't know if he's able to hear me or no.
No, you can hear. Dozie, can you respond, please?
Okay, sorry, Dozie. I'm so sorry. Yeah, Dozie, right?
Yes, Dozie. Yeah.
Yes, I can hear you.
Zibo, right? Dalurin Dozie. Yeah, go ahead, please.
Thank you so much. Yes, thank you, doctor, for that question. Yes, there is nothing serious about my age. If I had died, they will write it at the poster that I was 39 then. So,
okay, good.
I was just like I said earlier, I had just finished celebrating my 38th birthday. So,
wow.
So having gone through this thing, so the process, the rigors, maybe it took another 6 months before we could say it was cancer. So that's why I said it's 39. So
okay.
Having jumped out of 38. So
right.
And to tell you, so I had about 4.6 cm of the colon was cut off. So I had.
Yeah, sorry. So is it on the left? Was it on the left or the right side? That's what I meant. The location was it left or right?
It's on the left.
So on the left side, are you referring to the descending colon or the sigmoid?
Yes. Yes.
The descending colon, right? Is that what it is?
Yes, the descended. Yes.
Got you. Okay, good. Okay.
Yes. So I have about 2 cm now left to my anodes.
Okay, got you. Okay, good.
Yeah. So. Wow. Sorry, I'm an engineer, but I think I'm trying to close up with Dr. Evaristus.
Okay, that's fine.
Doctor, I know what I'm saying is very soon you will certify me a doctor. That's what I'm saying.
No, you answered your question. Thank you. Yes.
All right. So that's great to know. So the other thing, the follow up to that. So when they got the sample, was it tested molecularly? And what do you have any mutation profile on that or no?
No. So that's what I said. Then I was well, I will say I was naive. I was ignorant, but because I just wanted to know a whole lot of information. That's why I started now testing for the genetic mutation or that so many things I did with those samples then, but I can't just remember exactly now. But what I remember vividly is that it was a wide case, like that.
Okay. Yeah.
Dr. Val, thank you for that. We have Ms. Toby on the call now.
Yes.
Okay.
She's joined. Let's ask her some questions, please.
Okay.
All right. Good. Toby, we're happy that you have joined the webinar. Please, can you tell us at what age you were diagnosed and what led to your diagnosis? Were there symptoms? Please go ahead and tell us.
Okay. Good evening. Please, can you hear me?
Yes, we can hear you.
Yes, we can hear you.
Late. Okay, I was 18 when I was diagnosed.
Okay.
18 years. And the symptoms, I was having recurrent malaria and typhoid in the year 2021. From there, it graduated to me seeing blood and mucor mixed with my stool. Whenever I want to poo, I see blood and mucor in my stool. From there, I was losing weight. I was having loss of weight, loss of appetite, bloated stomach, loss of appetite after that, bloated stomach, and pain at the left side of my tummy. Yeah, that was like the major symptoms I was having.
Okay, wow. Please, good. Please, can you tell us what led to the diagnosis from the key events, from diagnosis to your treatment? Let's people get to understand your own is peculiar, it's different from Dozie, so that people can get to know.
Please, can you Ask the question again, sir.
Okay, we want to know the key events, those key events that happen from the diagnosis to your treatment. How were you treated? People want to know.
Okay. So when I was diagnosed in March 2022, uh, I was diagnosed in March 2022. I was told that it was a stage three. It
Okay.
was
Toby, did you
three.
get that?
Yes, she's answering.
Yeah, I was diagnosed March 2022. It was a stage 3 colorectal cancer, signet ring adenocarcinoma. So they said the first thing they will do is surgery. That's like the easiest way to cure cancer. So I was booked for the surgery. When the day of the surgery came, we did the surgery, but they said they could not remove the tumor because they met a frozen pelvis. Frozen pelvis, the tumor has attached itself to so many organs, so it will be life threatening to penetrate. So they brought out a colostomy that I have on the left side of my stomach. Now they brought it out that I'll be passing out soon because I had a colorectal rectal cancer. The tumor was in my rectum. So they brought out the colostomy that I'll be using this colostomy to pass out feces. The colostomy is the removal of one's segment of the colon removed to the left side of the stomach to divert feces. So they said when they could not remove the tumor, so I will have to go for chemotherapy and radiotherapy. I started my chemotherapy journey April 2022. I had my first 6 courses. After the first 6 courses, I had MRI test. When the test of the MRI came out, it was said that the tumor did not shrink, neither did it move from where it was. So I had another 6 courses, making 12. I had another MRI test, was the same thing. After the 12th course, they changed my drug to an IR type of chemotherapy. I had that one too, 12 times. Yeah, I was fed up. I said I went to meet my doctor to ask my surgeon to ask that okay, what can we do? I've been taking chemo, and I had radiotherapy too. At the middle of my chemo, I had radiotherapy, radiation to the pelvis. I went to meet him. I said I'm fed up. What can we do? I've been taking chemo, taking radio, and as we know, chemotherapy deals with the good and bad cells in the body. So the intake of chemotherapy, I had 21 courses of chemotherapy. So what can we do? This tumor is not shrinking, is not reducing, is not moving. So what can we do? So he said we have to go in to see for themselves because I've been depending on MRI test results to know the level of treatment, to know how well the treatment is working. So said they will have to go in, see for themselves if the tumor is something they can work with. So the day of surgery came again. I was booked for surgery. Fast forward to February 2, 2024. I started my chemotherapy journey in April 2022. So I had chemotherapy and radiotherapy for the whole 2022, 2023. I was booked for another surgery February 2, 2024. And the type of surgery I had is called APR, abdominoperineal resection. They opened me up. When they got there, they said they could remove the tumor. The tumor was still big, it was still very big, but they could remove it. It has detached itself from the organs that it was attached to, so they could remove it. And when they removed this, they said they could not remove the tumor itself. They had to remove my rectum with it because I said I had rectal cancer. So the tumor the tumor has already damaged my rectum. So they had to remove my rectum alongside the tumor and seal my anus. Now I have what we call a flat butt, meaning I can't pull from my anus anymore. When they removed it, they sealed me up. They said I would go for chemo radiation. I went for chemo radiation at LUT, Cancer Center, LUT in Lagos. I think I had 10 courses of 10 radiation to the pelvis, and I also had chemotherapy, the tablets over there. So after that, I've been living my life. That's like basically what I had.
Thank you. So going through, yeah, see when you were sharing your story, it's touching. Looking at what you went through, can you tell us what were your greatest support, your motivation in going through all this? because you looking at where the tumor was, how you manage the colostomy, and all the things that were involved. Please, can you tell us what people would like to hear? What were the supports, major supports that made you weather the storm of this colorectal cancer?
Okay, my major support number one is God, and after God is my family. After God, my family is my greatest support system, the greatest support system ever that I have with my family. Yeah.
Thank you. So can you tell us, looking back now at your age, 18 years when you were diagnosed, do you think, I don't know if there was anything that was done to check whether there was genetic thing involved associated to cancer at that young age. Was anything done, or they were thinking of, because we're talking at a very young age, to think of, begin to think of a lifestyle, which is unlikely. Was anything done to trace back in your family? Was anybody in your family, has anybody passed on, or anybody had colorectal cancer? Can you tell us about that?
Okay. Nobody that I know in my family had cancer, but my mom said a distant family of ours, maybe in a large extended family, someone had breast cancer, and that breast cancer killed the person a very, very long time ago. So yes, when they were asking me, do you smoke, do you eat it, do you eat that, I said no. Do you have any history of cancer in your family? I said no. But my mom sat down and she thought about it and said, okay, they have someone in their family that died of breast cancer a long time ago.
The last question I'll ask you before I give it to any other person that want to say one or two things before we start wrapping up, is looking at the diagnosis of cancer. From your story, you said that they said everything was dead. The creatinine was already destroyed, and meaning that it was an advanced stage that they picked you up the cancer. What would be your message to people now? What can you tell Nigerians and all other people that are over the world that will play this the video?
Okay, so my advice or what I can say is that no matter the stage you find yourself in, don't think all hope is lost, because I was diagnosed at a very young age and it was not an early stage of cancer. But I didn't give up. First thing is not to give up. When the inner man gives up, when you give up inside of you, then everybody around you will also give up. So when you as the fighter, as the person that is sick, do not give up, then there will be a strength. You just be empowered. The people around you will be empowered, will be strengthened. They'll be encouraged. You just see that you are encouraged. When you have that mindset of I have cancer, they say cancer used to kill. It's not even the cancer that will kill the person. It is that mentality of cancer kills that might actually destroy the person's life. So just take take everything a step at a time. Don't do what your doctors will not tell you to do. Listen to your doctors. That's like the greatest thing I can. Listen to your doctors. When I was sick, a lot of people were coming, oh, use this, use that. This one works better than chemotherapy. But we did not listen to anybody. Listen to your doctors, use your drugs, have faith in God, have faith in the drugs that you are using. Be positive. That's it. Just have a positive mindset. Don't you ever doubt that this thing will kill me. Have a positive mindset and you see that it gets better. It will not get better in a day. It gets better eventually. You see that everything would just work out. But it's not as if everybody survives cancer. No, it's not everybody that survives cancer. But just have that faith that it will get better for you. And you see with God by your side and with you listening to your doctor and using your drugs adequately, everything will align.
Thank you. Everything online. So we're looking at your story, having rectal bleeding, and for a long time, where people were chasing malaria and typhoid, chasing so many things. Every day, as the day passes, the disease was getting worse. So your story tells everybody that we should screen early. And if anybody has any symptom much early, the person should go and check it up. Because if they got checked up when the problem started, he may not have gotten to that stage at the time we were diagnosed. So thank you so much for sharing your story with us. And it will go a long way as people listen to you. Many people get to know what you went through and learn from it. I'll hand over to Dr. Lass because he has one or two comments to make before we wrap up. Dr. Lass, over to you. Hello, Dr. Lass.
Hello, can you hear me?
Yes, go on. Somebody wants to ask a question. Okay, Mr. Okay, you can briefly make your comment because almost the time is almost up.
All right, thank you so much, Toby, for your story. I really appreciate that. So I think this is just an open question, maybe to the panelists or to the team. So I can see, I mean, from my own vantage point, that Dozie's own cancer is quite different from Toby's question. I mean, her own cancer, because hers was more of a mucinous type, right? And I don't know exactly. Are they aware of the particular type? I know that, from our own presentation, it seems to me more of a mucinous thing. And from the history of having a distant relative who had breast cancer, I would think that this, to me, it sounds like a germline thing. So I think it would be important for her to be tested. I don't know what the panel or the team will do towards that, because it helps her as a patient. It also helps a very close relative. That's my own. And also for Dozie, I think it will be important for him to also know the genetic status, since he has a daughter. That way, everybody is well protected, right? Thank you. And thank you all for what you do again. Thanks.
Thank you.
Great comment. Thank you so much. Thank you. Over to you, Dr. Larson.
Hello. Eva, can you hear me?
Yes, I can hear you. We can hear you, yes. Go ahead, we can hear you.
Okay. Apologies, my network has not been very steady. Just to say thank you to Toby and to Mr. Dozie for sharing in their experience. It's been a very rewarding evening for everyone, and we are grateful to them for being kind enough and bold to share in their experience that serve as encouragement to not just their caregivers but to other patients who may be battling through colorectal cancer, and even those that don't understand the need to screen for it at this time. There are a couple of questions on the page. I'm not sure if we can attend to all of them, but I just want to also appreciate a lot of our colleagues and, more importantly, our teachers here. In no particular order, I see Professor Okonkwo on the call, Dr. Aderik Bigbe, the former president of Nigerian Society for Colorectal Disorders, Dr. Adejumo, and they've been making very wonderful contributions. Apologies if I don't mention names. There are so many people on this call. We are just very grateful to all for attending and making very valuable contributions to the discussion. Our MD is still on this call, Kenny, just to know whether he has any final comment before we wrap up.
Thank you, Dr. Lassie. Again, just to thank everyone for making the time to join this conversation. March is Colorectal Cancer Awareness Month, and we really want to make sure that we are spreading the message. Colon cancer can affect people who are much younger. In fact, that's the predominant pattern that we see in Nigeria. It's good that there are many doctors on the call as well. There was something that Dozie mentioned in his comments that he says the system, and you can see the comment section, the system fails to see younger patients in the system built for older patients. And often we see people who are in their 30s, 40s coming, I have blood in stool, I'm losing weight, and often we ignore and we think it may be nothing. We need to take these things more seriously now that we know that this is the predominant pattern that we see around us. Blood in stool in anyone who is above 40 should never be dismissed. We should prompt further evaluation. We also want us to take from this now that we know that the age for colon cancer screening for those at average risk is 40. So if you're on this call and you're 40, or you have siblings or family members that are Nigerian, you should let them know colon cancer screening is important. It should have started already at 40. But that's the message that we should have going from here. And for the survivors, we want to thank you for continuing to share your stories. People need to hear these things. There's nothing as important as storytelling. For people to see that, colon cancer is survivable. It's important that we detect it early and then that we focus on treatment. Again, thank you all for listening, and we'll continue to have these public health lectures, and we'll let you know as we have more sessions in the future.
Thanks, everyone. Have a wonderful evening. Bye.
Thank you so much, everybody.